Good morning, everyone. Great to be here. My role really this morning is to present the European perspective. As you heard, part of my role is to be founding president of the European Fit for Work Coalition. And that's a piece of work that really started in 2007. So I have to say it's really gratifying to see how active and thoughtful the Fit for Work Ireland Coalition is. And I really applaud the work that you have done. I think it's fantastic. I'm going to focus on three things, really. Looking at MSDs as a public health and workforce productivity priority, and I'll try and avoid overlap with what Ms. Costello mentioned just now in her presentation with lots of stats that I was going to use, but she has priority over me. Talk a little bit about what the sort of current state of play, both in the European Commission, but also in other member states, is, so that you get some sort of sense of what else is going on and how this priority is being addressed in other countries. And then to focus a little bit on what we've learned about what good practice looks like, but also what else needs to change. So there'll be my areas of focus this morning. Obviously, we've heard enough already about why musculoskeletal conditions should be regarded as a priority. One of the things that's interesting, looking at this issue from both a European and, in fact, a global perspective, is actually Fit for Work is now a global project. We're just about to start a piece of work in South Korea. I'm going to Brazil next month to talk about the launch of our Brazilian research and so on. So this is getting quite big. The harsh fact is that in terms of getting political priority, MSDs are high on what we call morbidity. So in terms of the burden of the condition on wider society and its costs, but it's low on mortality. Not many people die from musculoskeletal conditions. And the harsh reality is that when you're talking to organisations like the United Nations or the World Health Organization, it's actually quite hard to get the same level of priority or urgency about musculoskeletal conditions as conditions such as cancer and cardiovascular disease. Now, of course, we don't want to enter into what one of my colleagues once called the misery auction of comparing one disease group against another. But one of the problems about getting attention for musculoskeletal conditions is that whilst the impact is massive and sometimes devastating, it's quite hard in that political arena to get attention that it requires. And so part of the Fit for Work message is really trying to raise the profile of MSDs and both their economic and social impact. And that's something which I think, coalitions around Europe that echo and mirror what is being done here in Ireland are playing such an important part. First of all, I just want to give you some overarching sense of what the direction of travel is across the whole of the European Union over the next 20 or 30 years. There's some big things that we all know are happening, but will have a specific set of impacts on the health of the workforce and therefore its productivity. We have across the whole of the European Union an ageing workforce. We all know that. It actually plays out differently in different countries. In fact, in Ireland, that problem is less pronounced at the moment, but will be coming down the track. In many more countries, people are having to retire later. So actually, our definition of what working age means is also shifting. A friend of mine who I spoke to the other day, he's in his early 50s, just got a new job. In his contract, it says, your retirement age will be 75, which made him, double take, if you can imagine. He thinks he's worked pretty hard up to now, and he's now going to have to work for another 25, 30 years. So that should put him up sharp. And we also know that the burden of chronic illness in the working age population is also going to grow, partly because we're redefining what working age means, but also because although we've increased life expectancy, we're also spending more of our time in retirement or prior to retirement being unwell or having a chronic condition. So when you put all those factors together and perhaps overlay that also with increases in health inequality in Western developed economies, there are a number of macro trends which actually make MSDs a really important condition to think about. Now, in these boxes essentially are all the different consequences of having poorer health in our working age population. Lower productivity, higher proportion of people leaving the labour market early because of their condition, increased healthcare costs, reduction in tax revenue, increases in welfare spending, an increased burden on families and carers, and more social exclusion and poverty. And it shouldn't be forgotten, actually, that among those people of working age with chronic conditions who have to leave the labour market early, the biggest financial burden falls on them. And it's interesting to hear some of the political debate about welfare spend, which you see across the whole of Europe. When you look at the raw data on the impact of chronic health conditions on poverty, why would anyone argue that people make a lifestyle choice to leave work and go into poverty? It's really hard to see. So these macro trends are coming down the track. We know, just from the UK data, that by 2030, about 55% of the working age population will have at least one long-term or chronic health condition which will affect their work. So it's not a minority pursuit anymore. As we've heard, 80% of people in Ireland will at some point have exposure to a musculoskeletal condition. So this is actually normal, and I guess the challenge is, how do we make sure that through multi-stakeholder collaboration and coordinated early effort to prevent some of these problems becoming an issue, can we improve the situation and derive both economic and social benefits? So Ms Costello mentioned most of these statistics in her address, and so I won't go through them in a huge amount of detail. Suffice to say that MSDs in the EU are really very significant. I think the figure of 40 million EU workers who have an MSD attributable to their work is really significant. But we also shouldn't forget that there are people with musculoskeletal conditions which aren't caused by work, such as inflammatory arthritis and a number of others, where actually the workplace could be more friendly to them. You know, the working conditions or their ability to make adjustments at work could make it easier for people with those pre-existing musculoskeletal conditions to stay in work longer and to thrive at work. And the other thing I'd like to emphasise is this relationship between physical and psychological well-being. We know that up to 30% of people with a musculoskeletal condition also have a mental health problem for at least part of their lives. They're much more susceptible in some cases to having depression or anxiety. And this is what clinicians call comorbidity. And we know from a study conducted just last year in the UK that people with comorbid health conditions cost the health service 45% more, and actually have, stay in hospital longer or are under care for longer. So things that we can do to prevent comorbidity becoming a problem are, I think, also really important. We know from research that if you've got chronic low back pain, the thing most likely to prevent your early return to work is job satisfaction, not your back. It's your psychological well-being. So we need to think in a more joined-up way about how we deal with this. We also know there's the European Foundation based here in Dublin, which is an agency of the DG Employment in Brussels, has been doing research called the European Working Conditions Survey for several years. And what that shows is in some occupations, the risk of musculoskeletal injury is actually increasing because of poor posture or people having in jobs where they have to twist or make repetitive movements. Although we like to think that working conditions generally have got better, and indeed that's true, and accident rates have dropped, there are some occupations where the risk of acquiring a musculoskeletal condition have actually increased, and that's something we need to watch out for. In general, though, the conclusion is that MSDs are have a major and growing impact on productivity, labour market participation, social exclusion, and as the workforce ages and health spending is scrutinised, we need to look out for this much more, because I think that it's a slow burn, but really important threat. Now, there are a range of initiatives going on, both within the European Commission, but across the EU in terms of member states, which I think are encouraging. Although the first one is less encouraging, we have, since about 2006-07, had a draft new directive on musculoskeletal conditions going through the European Commission process. It's been incredibly slow, and actually all it is at one level is a pulling together of existing regulations around manual handling and display screen equipment, ergonomics and so on. And yet it's been very difficult to make progress on this, partly because of difficulties in getting through the social partnership and social dialogue process. And in the current climate, there are many member states who don't want any more regulation, and so that's been quite hard. So it's likely that that directive will be shelved, and there is a discussion now about whether or not there will now be a council recommendation, which I suppose is the next tier down of regulation, which we hope to hear about. Actually, I put November here because I did these slides on Friday. I actually spoke to the Commission official responsible for this yesterday, and he's hopeful there'll be an announcement by the end of May about this. But if there is a council recommendation, there will be an expectation that member states will take action to apply the principles and content of that recommendation. So we're hopeful that there's something that will come out from that. Of course, it does raise a question about whether or not you can tackle these problems just through the relatively blunt instrument of regulation. There are many people who argue that regulation is fine, but unless you have good implementation or enforcement of regulation, that doesn't do anyone any good. So we also need other things to make sure that progress is being made. So we know that also across the European Union, last year was the year of active and healthy ageing, and looking at health, looking at extending working lives and making sure people are working healthier was and remains an important principle, and there's still work going on under that. There's also a thing called a joint action on chronic conditions, which is looking at the burden of chronic disease in the European population, and a strand of work there which is looking at employment and work and the impact of chronic conditions on labour market participation. There's also an intergroup on rheumatic and musculoskeletal conditions in the Parliament, which meets very regularly and discusses these issues. And at last, there are moves by WHO, Europe and others to include MSDs as a priority amongst the list of non-communicable diseases, which I hope will raise its profile. Now, there are also initiatives in other member states. So, for example, I noticed in your pack, there's a short example from Madrid, where there's an early intervention clinic for people with musculoskeletal conditions, which seems to be yielding great results. And one of the principles of Fit for Work is that we know from the evidence that the earlier we intervene with people with musculoskeletal conditions, the more chance we have of helping them to remain active in the labour market, or if they're not active in the labour market, to return to work to a role which is suitable for their skills. And this piece of work in Madrid has had great success in accelerating access for people with MSDs to clinical and indeed psychological interventions that help them both stay in work or return to work, and it's also reduced both temporary and permanent work disability. And the economic evaluation shows that for every euro you spend in that evaluation, you can get up to 20 euros back. So the return on investment in some of these examples, I think, are very impressive. And actually, as part of the Fit for Work Europe initiative, we're now going to be rolling out examples based on that Madrid project in 2 or 3 other member states. And that's something that we're hoping to make a start on very soon this summer. I think the other thing that's really important is that across Europe, this issue of MSDs being a clinical as well as a labour market priority is being embraced by more countries. So we know now that, for example, in Finland, work as an outcome of treatment for musculoskeletal conditions is now a priority. We've got examples in Switzerland, in Israel, beyond the EU, now where vocational rehabilitation for people with MSDs, early intervention clinics are being introduced. In the UK, at last, we have just announced earlier this year a national clinical director for musculoskeletal conditions, whose role will be to set out a national plan to make sure that MSDs are given appropriate clinical priority. So what else needs to change? Well, I think one of the big things is that we need to think about work as an outcome of treatment much more explicitly. Sometimes when you talk to clinicians about whether or not they talk to their patients about their employment, you get blank looks. Here I am trying to treat the symptoms that are presented to me, rather than looking at whether or not work may play an important part in this person's life, and indeed have therapeutic value. We know for many long-term conditions, being in work has a much more positive impact on people's health. We've just finished a study in the UK looking at schizophrenia, where we know that people with schizophrenia in employment are 5 times more likely to be in functional remission from their condition. And the same story is echoed across a number of chronic conditions, and MSDs is not alone. So work in its broadest sense can be a really normalising, engaging, connecting activity. It can energise people if it's good work, and that perhaps is another challenge. It brings health benefits, a sense of purpose to people, and of course income. But too few people with MSDs are actually having a conversation with their clinicians about return to work. Now, we've seen big improvements here, but it's still the case that this isn't happening enough. So clinical interventions that support people's workability, that focus on their capacity, not their incapacity, are really important, and that's partly a mindset change. And that encouraging and supporting employers to make workplace accommodations that help people to stay in work need to be properly timed, they need to be resourced effectively, and also we mustn't underestimate the role the individual can play in managing their own workplace accommodations. Now, in the UK, we're just about in 2014 to introduce a new service, which you may be interested in as it evolves. We had a report by Dame Carol Black in 2011, which was a government-sponsored review looking at sickness absence in the UK. And one of the things she recommended with her co-author, David Frost, was that we should have an independent assessment service, which at 4 weeks of sickness absence, individuals should be able to refer to either by their GP or by their employer to get both clinical support to help them to stay in work or return to work, but also vocational support. And this is going to be rolled out in 2014. It's going to be privately delivered but publicly funded. It will probably be delivered by a combination of clinicians, occupational health, occupational therapists, physios and others. And it's been broadly welcomed by GPs in the UK because they argue that the fit note, which is our current sickness certification mechanism, can't deliver all the things that are piled on it in terms of expectations. And so I think many GPs recognise that actually the fit note can only do so much. If we have at the 4-week point an intervention that prevents people going on to long-term sickness absence, this could make a big difference. And also if that's given at the same time as giving people vocational support, for those people who can't carry on in the previous type of work they've been doing up to now, but who may benefit from retraining or vocational advice. We hope that that service will be a particular help to people who work in or running small and medium-sized enterprises who often get excluded from these types of interventions, because most big organisations have access to occupational health, but small firms don't. So we think that this new service may provide support both at the right time, but also to people who work in smaller organisations. So I think that the picture is much more positive in 2013 than it was in 2007 when the Fit for Work initiative started. Awareness is better, data is better, coordination between disciplines is better, a clearer understanding of the benefits of helping people with MSDs to stay in work and play an active part in work is better, but we still need to make more progress. We need to make sure that we've actually got practical interventions that we know make a difference and in the current climate can demonstrate that they at least wash their face financially. So looking at the economics of this is as important as the social and work-related impact of improving outcomes for people with MSDs. So once again, I'm fantastically admiring of what Fit for Work Ireland has been doing. I'd encourage you though, to continue to support this initiative because I think it's a really important one and can bring together people with different perspectives, which I think is absolutely fantastic. And it's been a great delight to be here today. Thank you very much.